Okay, good morning and good day, everyone. I want to welcome you on behalf of Wheels to our webinar on infrastructures for public healthcare systems. So my name is Nitish Thakur. I'm a professor of biomedical engineering at Johns Hopkins University, but I'm a proud alumnus of IIT Bombay and also in the founding group of Wheels and editor of Pan IIT Technology Review magazine, PyTech. You know, all of these are initiatives that were born out of Pan IIT USA's effort in Washington, DC, going back 2005. So we've been in it for a long time, but the Wheels is the most important initiative. It offers technology solutions for water, healthcare, energy, education, livelihood, rural livelihood, and sustainability. That's Wheels. So where solutions don't exist, we encourage research and development at IITs and in fact at other institutions through sponsorship. You know, Wheels works collaboratively with partners like IEEE, ISV, CII, Mission Samriddhi, Sevak, Spoken Tutorial, and many others. You know, we have embarked on integrated approach to smart village development. Care entrepreneurship is at the core. So this is a brief introduction of Wheels activity, but you saw a lot of that in the slideshow when you joined. So please, I want to remind you, Wheels is a volunteer organization. It depends on your generosity and of many donors. So we can only achieve or scale this up through leveraging both technology and your generosity. You can get additional information on wheelsglobal.org website. But, you know, let me take a moment to talk about just one example, very, very recent, as of even last few days. You know, I want to introduce Rajesh Chopra. He is an IIT Delhi alumnus and a founder of a company called TimeTex. It's a textile company, but they created an innovative silver nanoparticle infused masks. In fact, these masks exceed in their performance over N95 that now everyone has become familiar with. And just in last few days, we heard that this got approved by Indian authorities. And so Wheels acted as a catalyst, provided us support through some initial donation. So this is how Wheels can be a catalyst, a leverage for anything that is of global interest, India's interest. Okay, so this webinar, thank you for joining. It's made possible by a generous grant from Smita and Ashok Siddhanti of Endyna. It's an environmental health and safety consulting company in Washington, DC. Now, before we get started, also I want to give a disclaimer. You know, we have eminent speakers, but all views expressed by speakers are their own and do not reflect or nor are endorsed by Wheels Global and Charitable Foundation and its board and members. Some housekeeping messages, important. We want your participation, right? But please stay mute throughout the seminar. You will have opportunity to engage through the Q&A box. You may also send an email, info@wheelsglobal.org. So that's info@wheelsglobal.org, but you can use chat and we'll try to get to as many questions as we can, okay? In any case, all of this will be recorded and will be available on YouTube and Facebook, okay? So as we get going, please keep in mind, today's webinar is really important, right? Public healthcare systems, infrastructure. This is about delivery of medical equipment. You know, how many of us have had experience about oxygenator to be delivered and so on and so forth, the ambulances and such, and training of frontline workers. So pandemic has brought to front the attention that infrastructure, public policy, these are extremely important in the times of national calamity. And so these policies need to become processes and then become fast track into many things, drugs and device development, you know, skilled healthcare workers and ambulances and so on and so forth. We have all come to think of our public healthcare workers as the heroes and responders, and I think infrastructure enables them to do all that. So let's give them due recognition and put our effort behind this overall project. So today, we are very fortunate to have a panel of speakers who have managed a critical role in India's public healthcare system. They have enormous experience, and we need to listen to the recommendations so that we can manage this and perhaps future for pandemic. So we have four highly respected panelists, speakers: Dr. Sanjay Mukherjee, Dr. Kalyan Chakravarti, Dr. Manoj Mandal, and Dr. Ramana Rao. But they will talk about ground realities. Right? They know what things happen in trenches, like for doctors, engineers, NGOs, responders. So that ground reality is what we want to hear from them. They may talk about esoteric artificial intelligence and machine learning, or they may talk about practical infrastructure. So now, with that as an introduction, thank you again for joining us for this Wheels webinar. I now want to introduce Mr. Arjun Malhotra. He is one of our most distinguished alumnus of IIT Kharagpur. You can see his bio sketch. It's so long and so impressive. Besides, of course, the most important being an IIT graduate. He's a gold medalist and a distinguished alumnus of Harvard Business School, recipient of Albert Einstein Technology Medal, chairman of TIE Global and Global Pan IIT. These are our initiatives in the US. And of course, in India, he co-founded HCL and many other. He continues to be incredibly active in a variety of business and entrepreneurial, particularly philanthropic activities, including establishing GS Sanyal School of Telecoms and Farooqui Center of Innovation at IIT Kharagpur. So it can be a long introduction, but I would like to then hand over to Arjun, but before that, just one more plea. On behalf of Wheels, the infrastructure, deliver healthcare is really important, and we need your kind support and participation to build up the resources needed. So please engage. All right, well, thank you all for joining, and Arjun, can you take over, please?
Thank you, Nitesh. Thank you for that very kind introduction. I guess I can only go downhill from there, but thank you very much. It is my pleasure to talk to all of you today on this really important topic and, share the views from a really, really eminent panel who will talk to you a little later. I just wanted to make sure that everyone is clear on what is the definition of health. Health is a state of well-being, and basically healthcare infrastructure by definition is the basic physical and organizational resource needed for healthcare delivery. Now, technology, as I'm sure you would know, plays a key role in every aspect of this, and really healthcare infrastructure consists of bricks and mortar, transportation, medical equipment, pharmaceuticals, and telecommunications. So as you can see, how important technology is in terms of providing this infrastructure today. And we have, as I said, a very eminent panel with us today, and they will talk about many aspects of this infrastructure. I'm also sure some of you listened to the two earlier seminars on health that Wheels Global had organized. The first one was on public health in rural communities, and there are a number of takeaways from there. I'm not going to go through all of them because I'm sure you can see it on the website. And then there was a second one which was done in collaboration with Johns Hopkins on digital healthcare, and that is where the world is going today. And again, you can see all the takeaways from that on the Wheels Global website. So I won't waste everyone's time to go through that. But I think the COVID pandemic situation has brought this to top of mind for everyone, not just in India, but all over the world. But it has been a special issue for us in India because of the poor state of that infrastructure. As we go through the webinar, I'm sure you all will realize that we have one of the best foundations, but the poorest infrastructure or the poorest support for that foundational infrastructure in many ways in India. Excuse me. In many ways in India. And, I'm sure all of you will want to play a role in making a difference in a small way or a big way, depending on how you can help in making sure that we improve this so that when we are hit with this kind of problem in the future, we are much better prepared and we don't hear so many stories that get us so upset about the fact that we can't help and we can't control some of these problems that are happening. I'm not going to take more time. I'm sure we want our panelists to give us a lot more time and infrastructure. I don't see Dr. Sanjay Mukherjee on the call. Is Dr. Mukherjee on the call? Well, then we'll come back to him. He must be having trouble getting on. Let me introduce the first speaker, Dr. Ramana Rao. Very simply, Dr. Rao is one of the leading people in India in terms of emergency responses. All of you have heard of EMRI, and many of you probably know that EMRI provides ambulances in rural areas. It is one of the most advanced projects that has come up all over the world. And Dr. Ramana Rao is one of the key people in that. He is the managing director of GVK EMRI. And I will let him give you the details. He has a presentation that I'm sure he'll take you through, which will give you a much better understanding of the kind of work they do and the great impact that they are having and will continue to have on rural healthcare in India. Over to you, Dr. Rao.
Thank you so much. I just wanted to initially thank the Wheels Foundation for giving GVK EMRI to share some of our experiences. Is my screen visible? Slide deck? Is my screen?
Yes, it is visible. Yes.
Very good. Very good. Very good. Thank you. So I'm very happy that in the post-independent India, where emergency care access was not available for about 60 years, as a civil society organization in the South Indian city of Hyderabad, a technology-centered innovation has come up, which has bridged the access gaps in emergency care in the form of ambulance-based pre-hospital care services. I want to talk about it, but permit me to take back to 2005 situation where about 80,000 emergencies were occurring in India every day. And the gap analysis has identified that basically there were 4 A's which were lacking in the country. The first A is like 911, there was no unified 3-digit toll-free emergency number in India. There was not what I call a well-equipped ambulance was not there, and affectionate care by the trained paramedics and EMTs was not there. And as a 4th A, the affordability was not there because the cost factors were also very challenging. So with this gap, the organization Emergency Management Research Institute was incepted with a vision of saving lives. This ambulance-based pre-hospital care services, we feel that there are 4 wheels. One wheel is technology, the second wheel is leadership, the third is innovation, and the 4th is research and training. So with this, we have started our services, and I want to just take you
Dr. Rao, Dr. Rao, can I request that you go full screen so that's more visible?
Yeah, am I? Okay.
Yeah, very good. Thank you.
Very good. So anyone who is in distress can call this number 108, which is very poised for all the people with different faiths in India. And it's a toll-free number. The calls land in a state level, state-of-art technology-based center. We call it emergency response center or a command and control center, where a lot of technology, including GPS and GS, is ensured. And within 2 minutes time, the emergency location is identified, the type of emergency is identified by a drop-down screen, and the appropriate near-end ambulance is given an order that they should rush towards the emergency location. This is how our emergency ambulance looks like. In the patient compartment area, we have basic and advanced life support ambulances. We have taken into consideration or contextualized Indian emergencies. In other developed or other parts of the world, you will not find the patient attendance here, while in India, you will find a squad bench, because in rural areas, along with the patient, about 3-4 people also come along the patient when the patient is transferred there. And then the pre-hospital care starts. A trained emergency medical technician is there with the support of the MBBS doctor who sits in the state level emergency response center. Evidence-based protocols, which Stanford School of Medicine has immensely supported us, not only in pre-hospital care, evidence-based protocol in its revisions, in the training of the basic EMTs, advanced EMTs, and even the doctors who are all working at the district level hospital also. This is how we sense the emergency. We strategically reach the emergency by placing ambulances in a dynamic location, and we provide pre-hospital care. Not only the primary transfer from the say, for example, road, where a road accident occurs, from a workplace or from a home. And we also enable the inter-facility transfer from a lower level hospital to a higher level hospital. This is what we call sense-reach care paradigm. And we also do a follow-up. As I was mentioning, that technology was the core of this. As you would see that the technology, unlike 911, it has got an end-to-end connectivity, and emergencies are time-bound activities, time-sensitive activities. Whenever there is a deviation of an event or a process is disturbed, then automatically we have an operation excellence desk which would enable to contact the event, the person, and we will be able to rectify that. We also have apps in our ambulances which will show us the right route to the hospital or to the emergency location. We will also have a grievance redressal cell, and we have a system where almost all the ambulances have got a GPS coordinate. So whatever we do in the ambulances is also recorded like a case sheet in a hospital in the form of pre-hospital care record. And by applying Internet of Things, we'll be able to carry out a pre-arrival information to the appropriate nearest hospital or a destination hospital. Just look at the pictures where we try to create a first responder system as a part of the public health system, which was hitherto mystic. I want to give an example of the ambulance, which is now serving 4 months in a year in the highest village in the world in Himachal Pradesh called Killam. And we also have access problems even today. Some pictures from the foothills of Himalaya, from Rajasthan, from other places are also there. I also want to bring some cases where we attend about 25,000 emergencies. All ambulances do about 4 cases every day. 38% of the beneficiaries are pregnancy-related things. You would appreciate during the COVID time, our paramedics, by wearing a right kind of PPE, were able to provide safe delivery and maternal outcomes. In Gujarat, where in Rajkot district, Gir Forest, the lines were sitting on the road, our ambulance was stuck for about 2 hours, and the EMT in a safe manner has delivered triplets. Trauma is our second leading beneficiary. You would appreciate some of these cases, which may be a little gory for the common audience, but what I want to tell you that about 20% of every 5th case is a trauma related. We attend 5% cardiac, 5% the respiratory, and we also attend individual emergencies, mass casualties, and disasters. These are the wide spectrum of cases we see. And we work with the governments in a public-private partnership mode. In order to reach the last mile, look at the situation of diversity and complexity in terms of accessing the last mile. In urban small bylanes in like city of Hyderabad or Delhi, we have a two-wheeler ambulances. In tribal areas of Andhra Pradesh, we have a chole or a feeder ambulance, what we call it, has got 3 wheels. In riverine districts of Assam and in certain parts of Saurashtra, Gujarat, we also have a boat ambulances. In certain states, we have exclusive newborn care ambulances. In Goa, we have recently started the cardiac ambulances. Because we have hospitals, particularly the medical college or a tertiary care hospitals far away, we thought that in between we can create a stabilization center, we can create a higher window of opportunity for saving lives, and our emergency care centers are now expanding into more than. What I want to tell you is that wherever we found that last mile access challenges are there, we were able to create some innovation and we were able to bridge the gaps. We are not only serving the human beings. For the last few years, we have also started animal ambulances. Also, we call it 1962 mobile veterinary care clinics. This is how we have moved from 108 ambulances to other areas only with the help of the government, and we call it public-private partnership. In this about 15 years of journey, this is how the footprints of our expansion are there. The dark green is where we are working. The light green is where we were working earlier, and white areas we do not have services and our competitors or our other service providers are providing. Recently, we have started our services in Arunachal Pradesh, but we also serve Uttar Pradesh, which has got more than 200 million population. With a 14,000 plus fleet of ambulances, reaching about 800 plus million population, we are now referred as the largest EMS provider. On a given day, we receive about 200,000 calls. We respond to about 25,000 emergencies. And out of all the cases we have attended, say, for example, 86 million emergencies since inception, we had an opportunity to save about 4.3 million lives where there was a very critical factor. And you will be surprised to know that more than 500,000 deliveries were assisted. I'm using that emergency childbirth were assisted in our ambulances. We still do that about less than 100 on a given day. And every day we get an opportunity to save about 1,000 critical lives across 16 states and 1 union territory. With the advent of COVID, various governments have started working with us more closely. We are into testing, tracing, transfer, and treatment aspects of the COVID patients. Till date, about 2.3 million COVID transfers have happened in the 108 GVK EMR ambulances. And Honorable Prime Minister, in one of the meetings on Mann Ki Baat, has interacted with the pilot, and all our morale was really boosted up, and we are all called the frontline workers because 95% of our staff work in the ambulances. I want to close my talk with a statement that Dr. Abdul Kalam used to be our chairman emeritus, who always used to motivate us that the saving lives is one of the best things we can do. And this sort of a technology center system, which has got a synergy of information technology, telecom technology, fleet technology, medical technology, should reach all the lower and middle income countries. We are very fortunate to have Dr. G.V.K. Reddy, Padma Bhushan awardee, as chairman, and then he considered that this is a CSR of it, and he thinks that giving back to the society, the joy of giving back is what he always preaches us. Our international collaborations like Stanford have enabled us to bring the global best practices into India. I just wanted to close my talk with what Professor Prahlad has mentioned in his Harvard Business Review article while doing a case study on that. He said that this sort of innovations, leveraging technology as a part of the first responders in the chain of public health in this country, which was hitherto not there, and luckily all the Indians, it has become universal and ubiquitous in the country in these 15 years. Dr. Prahlad was saying that it is a Gandhian innovation. With less, we will have an opportunity to do more for more. And our saga, our mission of saving lives continues. Thank you so much for your attention. I'll stop here and hand over to the organizers. Thank you, sir.
Thank you, Dr. Rao. That was fantastic. I mean, I've got to congratulate you and your entire team and everyone who is involved in providing this service to so many people in India. And I know by talking to people when I've gone into some of the rural areas that they see this as a kind of a godsend in terms of how they respond to emergencies. So thank you very much. And, I am really amazed by the depth and the width of the service that is provided and how you get to, as you said, the last mile. And, I don't know how many people are aware of what you do, but it's good that you gave us a good run through. So we have a good idea of, at least I have a much better idea of the kind of impact that you are having in the country. Thank you.
Thank you,
It is
sir.
now my pleasure to introduce Dr. Manoj Mandal. Dr. Manoj Mandal is a professor at IIT Kharagpur, which is my alma mater. And I've had the opportunity to work closely with him over the last year or so on a number of projects, including his regular daytime job in terms of the entrepreneurship program that he runs at IIT Kharagpur. It is a very popular program. I understand some 700 students register for it. And so hopefully we will see more innovations and more entrepreneurs coming out over time. Dr. Mandal has received his higher education from IIT Kharagpur. He did his BTech, MTech, MBA, and PhD from there. He's also worked in a number of industries, manufacturing, banking, R&D management, technology intervention, and the technology intervention was for rural artisans. As I mentioned, he's presently teaching entrepreneurship, innovation, and finance at the Rajendra Mishra School of Engineering Entrepreneurship at IIT Kharagpur. And he has, as I again mentioned, a large number of students every year who seem very happy with what he teaches them. He has developed several technologies for rural artisans and is now engaged in developing healthcare equipment in response to COVID-19. And I'm sure he'll talk to us about what they're doing and why it's important. He's also received many laurels, including a gold medal for the best innovation by a consortium of Lockheed Martin, Stanford University, and FICCI New Delhi, amongst others. He has obviously a number of patents with all this development work that he does with IIT Kharagpur. I will hand it over to Professor Mandal. Over to you, Professor.
Thank you, Mr. Malhotra. Is my presentation visible?
Yes. Yes.
So at the outset, let me thank Will Global Foundation for having me here. This is a great opportunity for me to really talk to august audience like as I have in front of me. So I'm really fortunate to be here. So I'm not going to thank everybody separately. I'm not able to make the slide in the presentation mode. Is it in the presentation mode?
Yes, it is.
Okay, IIT Kharagpur has been working on several technologies. One of them is the point of care nucleic acid based rapid testing kit for COVID-19. That's a really frugal innovation in the sense that the total kit cost about 15,000 rupees or $200. With that, a person can start testing at the point of care itself, and each test cost about 100 rupees. It was developed by a team headed by Professor Shuman Chakraborty, and many other technologies are at different stages of development. I'll be talking about some of them. One of them is an indigenous ventilator that is also in the process of finalizing. I'm talking about some other technologies where this team that you see on your screen are trying to develop. As we all know that lungs is the ground zero for COVID infection. And as COVID infect our lungs, there is oxygen shortage. The moment there is oxygen shortage, COVID gets it easy to create havoc to several other vital organs, and then gradually deterioration happens. So providing oxygen, particularly medical oxygen, is one of the most important medication that we can think. Without that, no medicine is going to work. Now, the entire society, the world over, the entire society was taken aback, taken by surprise that so much of oxygen will be necessary to get rid of COVID. So we were kind of unprepared. We did have oxygen, but then transporting oxygen from plant and then dispensing oxygen to patient is a complex thing. And without training, without adequate tools, it was absolutely not possible. There are reports that many people were dying in absence of oxygen in spite of having oxygen in the store. So that was the situation at which time we were kind of exploring what to do. At that point, we realized even before that oxygen concentrator is a gadget that is something like a plug and play tool, which can be operated by anybody without much training. And at this point of time, IIT Foundation contacted us and saying that IIT Kharagpur must do something about this, whether we can develop an oxygen concentrator with all the support that they will provide. But then time was very tough. There was nationwide lockdown. We are away from a major city. Kolkata is about more than 100 kilometers, and the road was closed because of lockdown. And most importantly, the most important critical material that is zeolite was not available. Many people promised us to provide, but then at the end, all of them said sorry. So we got stuck, even though there was some funding from a private source. IIT Foundation promised fund. There was not much problem with fund, but then the critical components were not available. At this point of time, in this cloudy atmosphere, there were a lot of bright sun behind the cloud, and we got donation, we got help from various quarters. Padma Shri Dr. Ashok Gupta gifted us with one old oxygen concentrator with an opportunity to see what is there, because before that we did not have much idea about it. We see some YouTube video on DIY kit, etc. He also sent us a new Ambu bag, telling us that whatever we can do to make it a more useful tool. Then Gardner Denver gifted us 2 compressors. Before that, we were toying with Chinese-made compressors and it was not performing well, so we were kind of at a loss. But then when we got this compressors, we realized that this is perhaps going to work. We have a collaborator by the name MiFi. They had access to zeolite. Then they had limited stock, but then because they were partnering with us, they were depending on our development, we were depending on their development. So MiFi gifted us some quantity of zeolite with which we started building our initial prototype. As I said, IIT Foundation, particularly 1993 batch, was generous enough to give us sufficient fund. They just said, tell us how much money you need and we will make it available. One supplier from Kolkata unbelievably drove all the way from Kolkata to our place and provided all the components that were necessary, which otherwise would have been absolutely impossible from IIT for any suppliers to go to Kolkata and bring. Now we are ready with the product. We are ready with a tested product that can be given to anybody, and we have a mandate from IIT Foundation itself to provide this technology to any willing entrepreneur free of cost without any royalty or license fee. MiFi Care was our partner almost throughout, and MiFi is just ready to go to market with the joint design that we have come up, and they're just preparing. Any moment they will come out with a new oxygen concentrator that will be indigenous, that will have all major components from India, except zeolite. Zeolite is not manufactured in India. Just a few words about MiFi Care. It's a very innovative company. They have come up with a blood testing process by which a single sample of blood will do 160 tests. So our partnership with MiFi perhaps will take us to places not only with oxygen concentrator, but with many other things. Though we followed just reverse engineering, to be very honest, but there were some novelties. Particularly, India is the southern part of India is mostly humid. So handling humidity is a challenge, and we have done that. We have done the complete electronics that we cannot copy from anybody. And there are other small things where we had to really innovate ourselves and develop. So now we are ready to invite entrepreneur. The most benefit of this technology is that majority of the components can be sourced off the shelf, including the compressor that we have used. So that can be just replicated. Except zeolite, everything else can be bought off the shelf. So IIT KGP is offering this technology on open source basis, meaning that anybody interested to take this technology, we are going to help them 24/7 with any knowledge that they need. And if there is any troubleshooting, we'll be available 24/7 to handle that. So we are just going to handhold entrepreneurs. MiFi Care Private Limited, a company engaged in many other healthcare devices, are already a partner, and they're partner for oxygen concentrator. And we have another agreement for other two technologies I'm going to discuss moving forward. As I said, majority of the components can be procured off the shelf. All that an entrepreneur requires is the space where they will assemble the machine, and they need some technical skilled technicians, or say engineers, because these are sophisticated components, and then they need to have knowledge at the beginning. Otherwise we have to work really hard for them. We have to be there in their shop premises, which perhaps is very difficult given our academic compulsion. So not just oxygen concentrator, that's a standalone product, but we are going to offer multiple products, and they can target the same segment of the customers to market various products, so that they don't have to do customer acquisition separately for this product and separately for other products. As they can cater to single customer with multiple products. Now, people may think that COVID is almost kind of ending or something, and if an entrepreneur would like to invest, then what is the future? There are many ways of thinking about it. First of all, we now have just the Delta variant. There is a conjecture that there is going to be COVID-22 also coming, which is much deadlier, and will have a much higher viral load than compared to anything that we have seen, alpha, beta, or delta. So we never know how long this will persist, and how bigger complexity is going to create. Today's news is that US is finding oxygen scarcity as of today. So that shows the biggest supplier of oxygen is now finding it difficult to find oxygen. That summarizes in one sentence as to why we need to build new capacity for our own requirement. Third wave is just knocking the door. Not only that, moving forward, we must create our own capability. We should not depend on China or any other country for that matter. Oxygen concentrators is not manufactured in India, and we depend on other countries. Let me clarify why this is so very complex. First of all, whenever you buy something, there are multiple incidences of taxes. Suppose you buy a concentrator from China, there will be GST, local GST. Then there will be entry tax like customs duty. Then whenever somebody is selling that to the customer, there will be GST again. So there are three stages of taxes. Transportation, you name it, there are multiple addition of cost on top of that. So that is why our customers' purchase price becomes almost double, triple, etc. So if we can manufacture that locally, we can avoid that multiple taxation in different hands, and customers will be benefited. They can afford. Our small healthcare center in rural areas definitely cannot afford neither oxygen nor oxygen concentrator, because first of all, whosoever are manufacturing, they got this opportunity. They became knowledgeable about the crisis, and there is a surge price. When we wanted to buy one for our own experiment, we found that they have increased the price almost 100%. This is another technology. When an oxygen cylinder is fitted on a patient, the person, when he's breathing, oxygen goes in. When he's exhaling, breathing out, oxygen is wasted, because the cylinder is always releasing oxygen. Now we have come up with a sensor-based gadget that captures the breathing cycle, and it releases the oxygen flow whenever the person is trying to breathe in, and it stops the release of oxygen when the person is trying to exhale. Thereby, looking at this graph, when the person exhales, is a longer duration. There will be more than 50% saving of oxygen if we can implement that. It is being now given clinical trial by another company called Revolut. We have already signed an MOU for transfer of this technology. Absolutely open source, meaning we are not charging anything. Rather, we are helping that company for refining the technology and giving it the aesthetic design, etc. But Revolut again is a grassroots level healthcare delivery organization. They try to connect. They have this communication system, and they try to connect patients in the far-flung rural areas with the doctors sitting elsewhere for quality medical services at an affordable price. So we have just concluded agreement with Revolut, and we are very ambitious that this oxygen saver, we have named it economizer. So let us see how it comes. Now, alternative to oxygen cylinder is a very frugal device called bag valve mask, popularly known as AmbuBag. That's a trade name of a company, but this is just a frugal embodiment of oxygen supplier, or call it oxygen cylinder. It is the first responder under many contexts. Suppose there is an earthquake, there will be ambulances, but there may not be oxygen. AmbuBag actually is used in these cases for providing positive pressure ventilation to patients who are either not capable of breathing adequately, or they are not capable of breathing at all. So this is a hand-driven gadget. There is a bag made of silicone, and you can press the bag. There are one-way valve on two sides. When you press the bag, air comes to the nose, enters through the nose, and the other valve closes. When you inflate the bag, air along with oxygen, if there is an oxygen cylinder, air with oxygen will enter into the bag. When you press that, oxygen mixed air will enter into the nostril. Now that is very difficult to operate. It's a life-saving gadget, and it is an indispensable component of any ambulance for that matter. But then suppose you are going from Kharagpur to Kolkata, or say 100 kilometers, it will be a 2 hours journey. One cannot operate this bag for more than 10 minutes. That is why Dr. Gupta told us that do something, some technical intervention so that it can be operated for hours on end. So we have converted that into three different models. One is a very frugal model that operates with a lever. There is no battery, no electricity requirement. You just press the lever and deflate the bag, and the patient gets the oxygen or air, whatever you provide. Very simple, cost hardly 100 rupees to 200 rupees because everything is made of wood. It can be made of plastic as well. Second one is a motorized one that can be operated either AC or DC. If you are operating from an ambulance, you can just plug into the battery of the ambulance and it can operate as long as you want. Of course, there are regulators. You have to observe the patient to match the frequency of the breathing cycle with the speed of this movement of the thing. Third one is connected to the oxygen saver. That means whenever the person is actually breathing, oxygen saver will identify that, yes, this is the time when I should deflate the bag, and when he is exhaling, he will inflate the bag. So that will be much more automatic compared to the ordinary AmbuBag. So this will become something like a frugal ventilator. It does almost everything that a ventilator does. Only thing is that you don't have to insert the probe inside the lungs. But then if situation so warrants, you can attach that component, and then definitely it can work like a ventilator. Almost. We have not tested, just a hypothesis. But it is as good as that because we have a breathing synchronization system, sensor-based system. Now, in hospital, we all know that there are so much of cross-contamination. Many health workers acquire the disease from other patients, and many visitors who come to the hospital, they also acquire the disease. Not only that, there are multiple variants working in a hospital, means in different patients. So from one patient to another patient, there are incidences of multiple infection. You have alpha variant, you get the delta before coming home, and then many people are dying. Actually, not many people, there are incidences of death. What we have come up with is like this. We will dispense cool air or purified air from the top. We'll capture the entire used air from the bottom using suction, so that this air has no opportunity to intermix with other air. Then we force it to pass through several layers of filters, including ultraviolet C irradiation, to ensure that there is no pathogen left. We send this same air, recirculate it, and dispense that from the top of the bed. So it's a recirculation process after purification of the air. So there is hardly any opportunity for any pathogen to enter. So everybody is isolated. Every bed is isolated virtually. The same thing can be slightly modified with a manually or maybe just a motorized bellows to operate in residences like home in a hot domain, meaning wherever the pandemic is doing is very means infecting a lot of people in those domain, or in multiple apartments where if one apartment there is an infection, then it gets multiplied to almost all the other apartments. So this can be applied there, and the entire whatever air is entering into the room can be purified, and you have purified air moving in the room. We have come up with a suit that—
Professor Mandal, I am sorry to interrupt you, but we do need to conclude quickly because we have one more speaker.
Yes, sir, just one more minute. So we have come up with a suit, normally hazmat suit like this, the PPE that is popularly known. These suits are very hot because the layer does not transfer heat from the body, and the people get really feel really discomfort, and then it cannot be worn for a long time. It is neither very protected because health workers are getting infected. So we have come up with a system wherein we pass purified air. We pass air through some purification filters, and then we cool it using thermoelectric cooling, and then pass it in front of the nose so that the person gets purified air, and then we pass it through the body so that air actually circulates through the body and capture the sweat. In the process, it cools the body. And then when it cools the body, even the evaporation of the sweat gives a cooling effect. So that is about the technologies that I wanted to talk about. And the first three are absolutely ready, and we have already transferred to 2 companies. The second 3 are in the process, means some simulated models are ready, and we are coming up with a real setup, fabricating the real setup for first trial. Thank you very much for patient hearing.
Thank you, Manoj. Thank you very much. It's really heartening to know what institutes like IIT Kharagpur are doing in reaction to all this problem that we had because of COVID. And I'm hoping a lot of these see the light of day and actually go out and do what they're supposed to do, and hopefully provide the healthcare benefits that we all talked about. I look forward to it, and thank you, and keep up the good work, especially at the Center for Medical Excellence that you all have started at IIT Kharagpur. It is now my pleasure to introduce our next panelist, Mr. Kalyan Chakravarti. I worked with Kalyan for a long time. Kalyan is really what he calls himself the founding Sevak and the executive director of PARFI, which is a Pan-IIT Alumni Reach for India Foundation. This came up at one of the Pan-IIT conferences, I believe the one in Bombay. I think it was 2006, but around that time. And at that time, the IIT alumni sort of thought that we should, instead of just having these conferences, we should put something into action. And a number of initiatives were started. One of them really has expanded and is doing some amazing work that is led by Kalyan. I have the honor of being on his board, and so I really have a a seat to see how and what they're doing. And they started off with doing skills training with a guarantee of jobs. And that has actually expanded considerably. I'll let him give you the details, but basically they have a model where they've set up a private-public partnership with the Jharkhand government and are actually training something like 20,000 nurses every year. And when I went and visited one of their sites, the really nice thing was that most of the girls who were being trained had come from subsistence farmer families. That means their parents had less than 3 acres of land, and they were being trained to become nurses. And it was quite amazing to see. But I'll let Kalyan give the entire story. Over to you, Kalyan. Thank you.
Thank you, Arjun. That's 20,000 target. 2,000 is the current number. So thank you again. But quick one. Till when is 10 minutes? 15 minutes? That's the time limit. Because
yeah. Please.
I'm not sure the fourth speaker has come. All right. So I'll finish it in 15 minutes. Thank you.
Yeah. Then we'll have more time for questions.
Yeah. Wonderful. We'll do that. Thank you to the Wheels Foundation team. I think they're doing phenomenal work and really appreciate getting this opportunity to be able to present to such wonderful audience. I just had a small PPT, not too many slides, and also a video, so that that keeps things interesting. And as you know, today's topic is infrastructure for public healthcare system. And when we say infrastructure, we normally think hard infrastructure, but my endeavor in the next 15 minutes is to stress and point out that we also need obviously the human capital to kind of work with that infrastructure, especially in public healthcare. So the topic today is public healthcare education, a very interesting prescription, medically speaking, for both lives and livelihoods. So I think if we all remember, our entire journey through the COVID over the past 1.5 years, be it Mr. Trump in US and then of course Joe Biden now, or Mr. Modi in India, the debate has always been about lives and livelihoods, right? Obviously, locking down helps save lives, but it's at the cost of livelihood and vice versa. So we believe and we've understood that healthcare livelihoods is a very interesting. The point Arjun alluded to, that these girls come from very difficult backgrounds and they've actually been frontline workers. So that transformation of using healthcare education as a tool for kind of reconciling lives and livelihoods is probably the crux of what I'm presenting today. With your permission, let me start off with a quick video that I just wanted to share. It's a clip which is from the National Geographic piece that got covered when we did the work. I think before COVID, that they've actually featured this in their channel. So what I'll do is I'll just quickly jump onto it and let that video kind of show. Arjun, just tell me if it's playing all fine and everything else. If there's any problem, I will kind of change anything that needs to be changed.
It's playing. I don't have any sound.
Sound is not coming?
No, I don't
Now?
For India.
Yeah, it's coming very
No
low.
sound?
Just started.
Enterprise, led by the alumni of Indian Institutes of Technology, IIT, committed to creating self-sustainable business models that enhance incomes of the underprivileged. The foundation runs a demand-led training program that is a joint venture with the government of Jharkhand for skill development in the state, ensuring assured placement for students nationally and internationally, and a trained skill base for the industry hiring them. Candidates also receive a 100% skill loan through NABARD to support their training. The loan is only payable after the student has completed the course and has been placed in a job. This helps students from less privileged backgrounds to take advantage of the skilling programs.
ये नर्सिंग कौशल कॉलेज है और मेरी फैमिली कंडीशन उतना अच्छा नहीं है कि इसमें लोन प्रोसेस के द्वारा पढ़ाई कराई जाती है, जिसमें कि घर से पैसे नहीं लगते हैं। कॉलेज बहुत अच्छा है क्योंकि इसमें फैसिलिटी ज़्यादा है और यहाँ थ्योरी क्लास के साथ साथ प्रैक्टिस पे ज़्यादा ध्यान दिया जाता है कि इसमें हाई टेक्नोलॉजी के द्वारा पढ़ाया जाता है, जैसे कि सिमुलेटर है, यहाँ वार्ड बनाए गए हैं, जैसे प्रैक्टिस वार्ड है, ICU वार्ड है।
So that's the background of what we've actually done in kind of reconciling lives and livelihoods. So let me jump back to the presentation. I hope the video was useful and it gave some perspective of how we kind of use even technology to do this. So let me jump in. So we have actually been able to build India's largest public healthcare A&M education. For those of you from US, A&M stands for Auxiliary Nursing and Midwifery. It is equivalent to vocational nurse in the US, and in India, they are the frontline workers in the rural healthcare space. While the BSc nurses kind of man the corporate hospitals, it is the A&M workers in the rural hinterlands who actually are the bulwark of entire healthcare delivery, because the doctors are kind of shared, and then therefore there are only a few dedicated A&M nurses who are actually the qualified vocational nurses that man huge India's one of the large in the world public healthcare delivery system of primary health centers, etc. So if you look at it, India has, so the idea of IIT, the idea is to how do we bring the IITian spirit into healthcare education. And the Pan IIT Alumni Reach for India Foundation has managed to do that very quickly in 2018, and we embarked on it. We had a very low bar to kind of cross because in India not many public healthcare education systems were happening, and we managed to build output of 2,000 girls for can kind of concurrently study, and we are obviously wanting to scale that 10x to 20,000 over the next 3-4 years. And we are talking to various other state governments, and still India would be short of nurses. Just to explain, this is the kind of aspiration that there is for nursing in India. 17,000 kids from poorest to the poor backgrounds have actually written an entrance exam for 700 odd seats. So we have a very interesting admission policy, which is what we call as merit cum means kind of a policy, where there's a cutoff. And after cutoff, it's only based on your poverty that you get selected. The orphans and the particularly vulnerable tribal groups, they straight away get a shoe-in. They actually get admission without any issue. It is after that we actually have a very interesting this thing. So it's called the multi-dimensional poverty index, which is a UNDP metric, along with the BPL, which is the below poverty line index. So it's a very interesting science that goes into how do you measure the poverty and how do you rank people on that. If somebody is interested, we can do that offline. But the fact is, these are the case studies where somebody who actually lives in this kind of house, these are the parents of an agricultural laborer, not even a subsistence farmer. This person does not even own a piece of land. They actually have been able to send kids and who have actually joined Apollo, which is India's largest nursing provider, or any other kind of similar institutions. So what we do is, so therefore it kind of really alleviates the livelihood when poorest to the poor are given fantastic medical education, especially in nursing. They go out there and become both service-minded and also very sincere about earning and kind of helping their family. So it kind of is a win-win for their lives and the livelihood debate on both sides. So that's what happens, and we've got this to do a third-party study. We don't have time for it, but I'm just quickly kind of browsing through this. But very important side effect or a side benefit, the word I would like to use, is that when these nurses are in the training, they actually are affiliated to public hospitals, and they are working there as part of on-site training. So therefore, during their residency, they are actually kind of serving directly in these public hospitals and bolstering the manpower, because governments of India, India is a middle income country. We do not have the luxury of being able to afford enough nurses and staff that is required, especially definitely during a pandemic time. So these kind of trainee nurses kind of form a very good, what should I say, revolving system of, good quality human capital, cadre, that come and replace every couple of years when they graduate by a newer batch of people. and then the public health institution, which is affiliated to us, the public hospital, kind of benefits from unpaid, good hands that they can kind of support and then in kind of expand their public service offerings. So that's how India's economic issue about public health can also be addressed through the same lens of healthcare education. The interesting model, this is just an aside, not necessarily related to today's topic, is that it works on a skill loan model like the National Geographic video outline. The child has no upfront payment at all, zero fees. They actually kind of take a loan to the 100% of the fee structure, and then they get an assured job, so they repay through the salary deduction. So it's very similar to how education loans work in US. And one of the things that has worked really well is that we've actually done this with the collaboration of the state, and that's an important point to recognize, because India, you cannot do things at scale without the government support. I think this is what at least our experience has been. And if government and you have the same mission, which is of public service, it can really reimagine stuff. Government has provided a whole lot of infrastructure. So you can see our centers peppered across all the districts of the state, wherever that blue and green, pilot are the 10,000 capacity. These are the physical institutions, very left-wing extremism, saddled, and therefore it is kind of a public benefit or public service that is happening with through this education system that is serving both the government, the public, and the children who are actually coming forward to become nurses. So one of the things as part of our voluntary COVID, support that we've done, it's completely voluntary that we've done. We've actually done a whole lot of stuff. Starting with last year, we've set up a lot of RT-PCR labs, again in some of the remotest, what are called aspirational districts in the country. We've actually also piloted a very interesting PPP model for running these labs. So we've set up these fairly state BSL, 3 negative air pressure kind of lab quality, and we actually have very state-of-the-art machinery, but it is run by an ICMR, which is India's regulator for diagnostic testing. With them, one private operator who kind of provides the manpower. So with this combination of state-funded infrastructure and manpower coming from the private sector, we are getting the best of both worlds. And we've been able to really bring down the cost of RT-PCR testing in the country, in this state especially. We today handle 65% of the state testing capacity directly from the lab set up by the Pan IIT Alumni Foundation. So it's a phenomenal, learning that we've got. We've got an opportunity to voluntarily contribute to the state in a very, very direct way. And most importantly, in India, like I said, there is a lot of resource crunch for public health care. So if you can minimize the per capita dollar, you can serve more people, because we virtually have unlimited population to kind of test and take care of. Similarly, we've also upgraded, with oxygenation and state-of-the-art ICU facilities. A lot of the description that came both from the earlier ambulance presentation of saving lives, and therefore the importance of a ICU kind of a unit, and the entire ventilator technology that Professor from IIT Kharagpur spoke about. I think it's phenomenally very useful. We put some of the best tech out here. As you can see, some of the Stryker beds, which are very similar, I'm sure, from some of the US hospitals. So state-of-the-art, world-class ICU upgradation, and this is the Apex Hospital of Jharkhand. Now we are replicating it to other states. So similarly, with the Principal Scientific Advisors Office of the Government of India, we've actually been doing training of COVID technicians. So we've done a whole lot of training. This is Professor Vijay Raghavan, who's actually doing this, and he's kind of been inspirational for us. And he's helped us in terms of in launching this. He's the PSA to the Prime Minister. This is some of the, had a live lab where they had to test some of the COVID samples. So it's been a fantastic learning that way. And we also trained some ASHA workers and nurses, which is in the entire COVID protocols and oxygenation. So it's the manpower that mans the infrastructure that is equally important. And I just wanted to leave all of us with this, should I say, Thanksgiving that we should remember that, basically, of course, some of you might be following the DC versus the DC Comics versus the Marvel universe of superheroes. But the real superheroes, of course, are the COVID warriors, the healthcare workers. And I think we should take this opportunity to really thank them and, more importantly, invest in their education, in their capacity building, and really prepare ourselves with an army of healthcare workers for the future pandemics and future waves. Whether they come, when they come, does not matter. The fact is, we need to invest on this. That is what COVID has taught us. And this is a very good investment that just not only benefits public health infrastructure and the systems, it also benefits some of the poorest women who will become breadwinners in this entire, healthcare livelihood world. So it is kind of a win-win which we can all drive towards. So thank you again for giving me this opportunity. I wanted to keep the presentation very short. I had my 15 minutes and it's 8:36, so that's about it from my side. Thank you.
Thank you, Kalyan. That was very illuminating. I just wanted to also clarify for people who are not aware of the people healthcare infrastructure in India. Every village has an ASHA worker and an Anganwadi worker, as we call them. And every group of 5 or 10 villages, depending on the population, or some number in between, has what we call the auxiliary nurse midwife. So technically, we do have the infrastructure of people on the ground in India. Unfortunately, as we have seen, they don't really share data effectively, and therefore they're not as effective as they should be in terms of providing the services. And there's a lot of work going on by a number of organizations to try and set up processes that'll get them to work. And I just wanted to give that little background because people heard names like ASHA worker and auxiliary nurse midwife, and I guess no one mentioned Anganwadi workers. But that's basically what exists in India. So the infrastructure of people infrastructure exists. We just have to make it efficient and effective. With that, I'd like to thank all the panelists, but I'd like to invite Nitesh to join us now and see if there are any questions that the audience has put up that we'd like the panelists to answer. I had one question, so before you start, I had one question that I wanted to ask Professor Mandal. Said, why is India lagging behind other emerging countries in healthcare-related hardware? And why do the rural poor struggle to find basic health facilities?
Thank you. Well, the question actually is very involving and cannot be answered straightforward just like that. We have enormous opportunity landscape in rural healthcare because so many people are crying for healthcare, and we have so many entrepreneurs on the other side who are kind of struggling to find an opportunity. Whenever there is a pain, there is an opportunity, but then we don't find that there is a match. There is a pain. There are people who would like to start companies to alleviate that pain, but then there is no match. The reason is like this. Our entire system since independence are urban centric. So majority of the healthcare, even government hospitals are agglomerated in the urban centers. So whenever some rural guy falls sick, seriously sick, he has to come running all the way to urban center. First of all, the transportation cost. Second of all, they have small savings. Then they have to stay somewhere in the city. The expenses are multifarious. So I would say that there is a cascading effect because of this agglomeration in the urban centers. Cascading effect in the sense that a farmer who has a small saving, once he falls sick, he becomes poor. He becomes an absolutely poor guy because he has to spend so much of money. So gradually, our poor people are becoming poorer and poorer. So the system actually is in a way, in a repeated manner, is making people poorer in the rural villages. So they are neither getting access to healthcare nor we are doing anything to reach out to them. Like Mr. Kalyan has given a wonderful example, and I want to refer from there. They are training Adivasi girls in the rural areas for doing a job in their areas. That validates one point that I always want to make is like this. We can actually train rural people to become a doctor for the rural people. There may be argument against that for training it means for making a doctor, you need so much of training, so much of other infrastructure, but we can make a hub doctor, just like these ladies who are becoming nurses, with these Adivasi girls after a short training, not a big training. And we have seen the picture that was shown. It's hardly anything. It's just a classroom in a rural setting. We don't see a lot of laboratory equipments and all that. So it's kind of a half nurse that you make, but then they're good enough. One hypothesis that we have is if somebody doesn't have a good score like CGPA of 9, he cannot become a good doctor. But my view is very different. I see that many students who do not have so much of cognitive skill, but they're innovative. Many doctors who did not score so well, they become good doctors because they use their creative side of the brains and gradually they learn from their own experience. What I'm trying to drive home is that we can actually have a second level of doctors, not the first level of doctors, MBBS and all that. We can have a polytechnic kind of doctors. They will be trained only for villages, keeping in mind some vacancies in a healthcare in a village. So suppose I am a villager and I compete in a competitive exam to become a doctor in my own village, and you train me in some setting, I become kind of a half doctor. That way you create infrastructure in the village. And the moment there is infrastructure in the village, there will be a lot of economic activity happening around that. And then entrepreneurs will identify opportunity in the village. Now entrepreneurs are identifying opportunity in cities because city hospitals are in the cities. So they are talking to doctors in the cities, and then they are importing equipment because there are limited number of hospitals. The moment every village becomes an hospital, there will be so much, means the market will be a huge market for entrepreneurs. You will find innovations happening, and then a small gadget that can treat the villagers, like I showed MiFi, the company who is an Indian company, first generation entrepreneurs. They have come up with so much of innovation. These are going to happen, and then you will find that employment in the villages increases. When employment increases through this process, meaning obviating the expenses that they're incurring for going to a city hospital, that will give another upward cascading effect, meaning they save their money, they go to a local doctor, they learn more about hygienic practices, and eventually there is an upward cascading. And you will find that rural, most important factor is that we cannot subsidize, like what I forgot the name, first speaker, Mr. Rao. What Mr. Rao has demonstrated that from corporate houses, they are helping the villagers. This model, to me, this model cannot be a sustainable model because you cannot reach out to everybody in rural areas. You can reach out only by making it self-sustainable. If it has to be self-sustainable, the rural people themselves should help themselves. Like you create some facilities so that rural people become educated, they treat themselves, they don't come to cities. By improving their own infrastructure by them is a sustainable model, not helping them.
Can we, if we can keep things short so we can take some questions.
Thank you, I'm done.
Thank you.
Sorry for.
Go ahead, Nitish.
Yeah, so first of all, for all the audience, it's important that you participate in this conversation. And so either through chat room or a document that we have posted through a link, you can pose your questions. And our panelists, please, as appropriate, you can respond to the question. So I think there is a really good, interesting question. Arjun, you can probably coordinate about the intellectual property and innovation, such as what Dr. Mandal has described. So Arjun, maybe you can share your thoughts on how, and then maybe pass it on to one of the speakers.
Well, what is the question? Because
so it's about how do you manage intellectual property in India, and how do you reward people, right? Because the work done at IIT is somewhat altruistic, but how do you protect intellectual IP and how do you reward the inventors?
Okay, so I think my experience has been, and I go back and quote the late C.K. Prahlad on this, that you can make money from the bottom of the pyramid. And so technically, while you might want lots of royalties and stuff like that, I found in India, at least in healthcare, and in education, if you are able to provide the masses with some basic technology-based solution and charge an affordable 15 rupees, 25 rupees, some number that's affordable, that provides them benefit, the volumes pay for whatever you need. Yes, there's some initial payment you got to make, initial investment you got to make, but the volumes pay for it. So it's very much like a SaaS model, but done at the consumer level. That's been my experience. And, you know, I work with a company that's in telemedicine, and at 25 rupees per consult, they are billing 4 crores plus every month. So, and it's going up by about 30 to 40% every quarter. And so, yeah, I mean, I won't use the word infinite because we all know that's too big a number, but I would like to say the market is near infinite in India. So I don't think we need to worry about intellectual property and all that. Yes, when you're charging 100,000 rupees, then you're worried about how many people are going to afford it. And you need to make sure that you get paid because there's a small volume. But if you, as I think Dr. Mandal said, if you are able to get and put a person in every village, I mean, the number, if you get 10 consults a day, that is enough to pay for someone to earn 15, 20,000 a month in the village as well as make it sustainable all over. The problem we're going to have in India is there are not enough doctors to provide that kind of calls. So we'll have to find a solution to that. And I don't have the answer right now. But as you put telemedicine in and it's starting to come in, we'll have to find a solution. Yes, Dr. Rao, I think you had a thought on that.
Yeah, no. I just want to supplement what Dr. Manoj was mentioning. Having realized that the qualified MBBS doctors may not be available in India, under the auspices of Public Health Foundation of India and the National Health Mission, a 3-year degree course sort of a thing was experimented both in Chhattisgarh and Assam. And a study was also published comparing the clinical acumen and their ability to serve the common diseases in the rural India between MBBS doctors, from the Ayush stream, and these doctors, I think they are called community health officers, where the prevention, promotion, and the treatment of the common ailments was a focus, leveraging the standard treatment protocols. So at the end of that study, it has revealed that they are able to create a right kind of mix of project management. I'm talking about healthcare delivery at the primary health center as a project and the clinician role. But however, the private sector in this country, as you know, that is contributing to 84% of the treatment in the morbidity, and out-of-pocket expenditure is very high. And 60 million people, as per the National Health Policy 2017, are incurring catastrophic expenditure where medical emergency is one of the important things. So there are 2 points I wanted to allude to the group. One is that there were some experiments. I'm using a word called Indian medical doctor is what the competency-based education of the National Medical Commission is trying to do currently. And there was an experiment for a degree type of a course like a BSc Community Health Services or officer, which was experimented both in Chhattisgarh and Assam. And if you go by the National Health Mission documents, it will also get more details. Somehow it could not really expand to other areas. The other point is that the rural population, now, as you know, that by 2040, 45% of the population would be in urban areas. So I want to take the example of Kerala model, where the average village size is about 10,000 and the MBBS doctors are able to meet both the ends. So what I want to tell you is that as we are increasing our telecommunications, as the roadworthiness of the villages and connectivity is getting increased, and I'm sure that in about 5 to 10 years, that the rural and urban differentials will come down because the population would be there. and more people will be able to access. Another study which has revealed that around 5 kilometers around the primary health center, majority of the patients are going to that primary health center for taking treatment. Beyond 5 kilometers, people are not availing. So the mobile health services is also coming out as a part of the initiative of the National Health Mission, and it is also able to bridge these things. So there are other methods which are able to augment to the infrastructure, a static facility and a mobile facility, and some sort of a deprofessionalism is also very important in the current context. So over to you.
We have limited time, so let's take a couple more questions. Dr. Shah, you have your hands up, so can you speak up? Dr. Shah? Please go ahead.
Yeah. More than a question, this was amazing way of bringing the whole concept of infrastructure, whereby roads, transportation, delivery care through emergency mobile services, as Professor Ramana Rao mentioned, frugal engineering to have medical equipment, some example, how it can be made available at a lower cost. Kalyan Chakravarti mentioned about healthcare workers, how they are, how we can take those people and create a healthcare force. But that when all said and done, which are phenomenal way, the whole infrastructure in public health can help us to deliver care to that last mile, to that villager. Remember, these are the people, they don't have anything. Till we create and convert every village into the smart village, where adequate needs for happy lifestyle is available, the education for children is available, the schools are available, the hospitals are available in every village, which is a very tall order. Till that happens, once that person gets educated from that village, he's going to migrate to the city. Nobody wants to raise their family in those villages where there is no education, no other infrastructure. Therefore, I think the way we have kind of brought this thing all together and delivering to that last mile, I think, as Arjun mentioned, telemedicine, the remote care, remote delivery is going to be the key, and how we can make it technologically possible and how we can deliver it at a very cost-effective way. And I think that's what Wills has done to create its own telemedicine program, taking it right to the doorsteps of villagers, and in a very, very small amount, just $1,000 can create a hardware, and then a very small fee paid by villagers to support the software and ongoing, which generates a salary for 2 people in that village. And that's overall how Wills is putting all these things together. And that was my comment more than a question. But thank you, Nitish, for allowing me to, because this is so much at my heart. And this is one of the overarching things that Wills and I'm involved in doing. I'm happy to say we now have more than 400 telemedicine sites in 7 states. And we already served more than 5,000 patients in the last 2 months, free of charge for COVID. And this is something we want to expand. And I think everybody from all the speakers and all of you come together so we can really do and provide that service to that last mile, to that last point, to that villager. That's right. Thank you.
In fact, it takes into the last question in interest of time, and then Arjun, I'll hand over to you for some comments, and then I'll do the closing. So the question is about the Uttarakhand experience and Parfi. So Arjun, you can coordinate that one to see whether the question is, can it be scaled up to other states and more broadly?
So Kalyan, that's something that you're on mute, but maybe you want to talk about how you can expand
we are actively speaking
to other states.
Absolutely, completely on board. We want to do this. So we are speaking to Bihar, UP. Our focus of Jharkhand was because it's one of the bottommost HDI states in the country. We want to expand to similar other states, Uttar Pradesh, Assam, Bihar, Jammu Kashmir. Though it's not a bottom HDI, but it has obviously been struggling. Odisha, so Chhattisgarh. So if any of you can kind of facilitate that, please do. We are anyway independently speaking to various state governments. Hopefully it will get replicated starting next year once COVID is over.
Yeah, so please get in touch with Kalyan or get in touch with any of us and we'll connect you to Kalyan, and he'll be very happy to work with any other state. It'd be nice if you can give an introduction to the appropriate people there. That will make it easier, although they are trying themselves to get that connect. But yes, it would be fantastic. And the other thing I wanted to mention, Dr. Rajha, thank you very much for giving all that information. My experience with one of the NGOs I'm connected with in Rajasthan that addresses infant mortality, malnutrition, and maternal health is that we found that class 11 and class 9 girl students were like an army who went out and educated women in the village, mother-in-laws and women who were expecting. And their word was taken seriously because they are from the village, basically, and being educated. But the important thing was in talking to them, they prefer to live in the village, but want a better quality of life in that village itself. So I think that is the big challenge for us in India, is how do I make a better quality of life for people in the village? Then the educated will stay back and do things. And, then it becomes a positive kind of cycle that will happen. I think Professor Manoj Mandal referred to that too. I think that's the key. And healthcare is just one aspect of it, but an important aspect. Over to you, Nitish.
Thank you, Arjun. I know I'm going to read a comment made by somebody here, Rajesh Chopra, that so much to learn and imbibe, and that I too will do my responsible work and towards society in the future. So, you're already, that's a nice statement, and you're already all of you making an impact. So let me, in the interest of time, make some, help with some of the closing comments on this. But, first and foremost, we have to start with thanking all of you, the panelists, Arjun, you for your incredible leadership, and in fact, some of the words of wisdom here. Dr. Raman, Dr. Rao, Professor Mandal, and Kalyan, all of you did great. I mean, insightful comments. We had a wonderfully moderated session, thanks to you, Arjun. So I really think you guys have helped make this event work. So this will all be on the website for sure. For those who have not been able to attend, bring it to their attention. There is a donate button there. So Suresh, are you there? Can I invite you to make a pitch? Don't be shy on behalf of Wheels Global.
Thank you very much. I echo Nitish's comments about this particular panel, and thank you very much for sharing your expertise and your experience. We got a lot of good comments from a variety of sources. Thank you very much. This is the third in a series of 4 webinars that we've been hosting about lessons learned from the pandemic and what changes may be required in terms of technology adoption and policy. The final webinar in this series of 4 will be held on September 25th. And I just want to make a note that it will be a phenomenal panel as always, led by Ambassador Pradeep Kapoor, who is the author of a book on COVID-19 and envisioning a better world by transforming the future of healthcare. The panel will be moderated by our chairman, Rajat Gupta, who is one of the founders of the Public Health Foundation of India, along with Arjun and others. Our speakers will include Dr. Krishna Vatsa, who is a member of the National Disaster Management Authority. He will be joined by Dr. Srinath Reddy, who is the CEO of the Public Health Foundation of India, and also and by a couple of others who have been invited. So please join us again on September 25th for this concluding series of webinars on lessons learned. And the title of the webinar on September 25th is The Role of Public Health Policy and Digital Healthcare Systems. As Nitish has just indicated, Wheels Global Foundation is a charitable organization, and we depend on donations from our well-wishers and our audience. Almost all the money that is contributed is used and for projects that we have outlined in these webinars. Almost all the overhead is covered by the board of directors. So any donation you make is utilized for the purpose that it is directed. One of my colleagues and our board member has also talked about the work that is being done by the Wheels India Nishworth Foundation in water research and healthcare. There's a lot of work going on at IIT Gandhinagar, IIT Kharagpur, IIT Bombay, and Guwahati and other places, which are also funded through this WIN Foundation and the generous donation of some of our patrons. So thank you very much. Please join us in this journey to apply technology to scale philanthropy, and also to help the Indian government and also the US government in formulating these policies that will help to address future pandemics and potential variants and so forth. So thank you very much. Over to you, Arjun and Nitish. Thank you very much for your leadership.
So I'll just take a few takeaways and then hand over to Arjun to close the event. Okay, so I mean, there's just so much being said that, you know, it's difficult to put it all together. But, you know, as an engineer, IITian, I feel like technology is clearly at the heart. We discussed topics of IP, but Arjun made a case that bottoms up, that brings up the old memories of that seminal work, that even through bottoms up innovation, we can help India, the rural and poor communities. This was about infrastructure, and we've seen it in many ways, and even Uttarakhand example, but now we know that it's being scaled up to other states. So I think that's an incredibly important takeaway. I think we heard about the emergency health services, the role of doctors, but some of the Q&A people also brought up nurses and staffing, because they all have to go in together.